My name is Dr. Eugene Tuyishime. I'm Assistant Program Director for Anesthesia Residence Program at the University of Rwanda. I'm also the CEO and co-founder of the Initiative for Medical Equity in Global Health, a teaching organization providing resuscitation training across Rwanda. So I'm excited to be part of this good conference of the 9th All African Anesthesia Congress. Thank you for the invitation. So the title of my talk is about challenges and solutions of implementing resuscitation training courses in rural resource settings. This is the experience from our group working with public hospitals in Rwanda. Before we start, I want to give a little bit of background about where we're located. So Rwanda is located in East Africa. It shares borders in the west with the Democratic Republic of Congo, in the north with Uganda, the east with Tanzania, and the south with Burundi. It is now known as a good destination for conferences. As you can see, we have a nice Kigali Convention Center. We have good touristic attractions. It's one of the best places to go and see the gorillas. We have good sport facilities. You can see the Kigali Golf Club. And we have some of the top universities in Africa, like the University of Global Health Equity. So let's go back to our presentation. So the objectives for this presentation are to highlight challenges of implementing resuscitation training courses in public hospitals across Rwanda, but also to discuss solutions we have provided while contributing to a successful implementation of the local resuscitation training for public hospitals in Rwanda. So as a background, there is a disparity in survival rate after cardiac arrest if you compare high-income countries versus low-income countries. So you can see that the mortality is about, the survival is about 18 in high-income countries, while it is still very low in low-income countries at 4%. So, and because there was good cardiac arrest teams, resuscitation training like ACLS, resuscitation research, and the quality improvement, which have led to better outcomes in high-income countries despite having complex and a very sick patient. So we have unique obstacles to effective resuscitation in low-income settings. One of the issues is that there is not enough staff who have the expertise needed. But also there is insufficient equipment and drugs, where some hospitals lack defibrillators, EKG was not available to every patient, and some antiarrhythmia drugs on SLS algorithm were not available in some hospitals. On top of that, there was lack of access to adequate resuscitation courses for everyone in the team, and the insufficient data and the research to improve the current situation. If we can go a little bit in details about the challenges we have faced, is that there was lack of context-appropriate resuscitation courses, and some of the courses were just taught by teams from the US or Europe, providing the courses which were not adapted to the context. Again, there was insufficient trainers. So some Ugandan anesthesiologists, EM physicians, and pediatricians have been delivering courses, but without a good national coverage. I would just add that for the pediatric program, they have some courses which, because of good funding and prioritization, which has reached almost the whole hospitals. But for adult, there is still a big gap. There was also issue of insufficient simulation equipment in some of the hospitals. Most of them were available at the university and the private schools and a few hospitals, but still they were not easily accessible because you need permission to move equipment from one place to the other place. So inadequate funding, that was a big issue because there is competing priorities from the hospitals, the university, and some NGOs, they have also priority for maternal and child health. So we thought also there was a sustainable delivery model because those American Heart Association courses were expensive, inflexible. You can't change the curriculum to fit the local context. And also you need a lot of reporting. Also, it required international faculty coming from the US or other countries. That was more not sustainable for most of rural hospitals. So what did we do as a solution? So first, we have improved the courses to meet the context by contacting the National Healthcare Professional Solutions to adapt content to our context. So we increased the time required for EKG training, and we added some EKG slides, and also we added some non-technical skills courses like VAST, which is vital anesthesia simulation training. We added some new scenarios to fit the practice by focusing on young mothers coming for delivery, trauma, and infections, which are very common in comparison to uh, patients with non-communicable diseases and elderly, which are common in the US and other high-income settings. We also added the local drugs to the ACLS algorithm. The issue of lacking enough trainers, we managed to provide instructor courses and the experience to more than 20 anesthesiologists. And also we still have a collaboration with the Rwanda Society of Anesthesia and Critical Care to make sure that we have a pool of enough trainers. The issue of equipment, we managed to get donation from Radio Foundation, but also we bought our own simulators, and we still have a collaboration with other NGOs like Vital Anesthesia Simulation Training uh, Group, and also the Health People Rwanda, which is another local non-for-profit organization. In the issue of inadequate funding, we got some grants to do research and quality improvement from the WFSA and also VAST. We got also direct funding from hospitals to organize their courses to meet accreditation requirement. And also we use the university faculty and also the facilities for students. Also, I would like to add that for sustainability, we managed to create our own learning management system where we provide courses for 1 to 2 weeks before, followed by 1 day in-person training to minimize the time out of clinical practice, but also the cost. And we also use the facility at the hospital and at the university to minimize paying expensive uh, fees for the hotel. We also value faculty development, where we include young faculty, either resident or also other members of the group, like non-physician anesthetists and the nurses when needed. So this is the table showing the schedule of most of our courses, including the BLS, ACLS. We have also a version for 1 day for both ACLS and PALS. We have now access to Safe Obstetrics online, which is very helpful. We are planning to include Safe Pediatrics as well. We have VAST. So this is some of the courses we have been delivering. So this is to show our online learning management system where students can do self-learning before they come for in-person training and practice. This is very helpful because it reduces the amount of days they want to be out of clinical practice. But also they have access to the content to go back to the content if they need more information or to remind themselves about what we discussed. The achievement so far, we have completed more than 40 sessions of different courses. We have reached more than approximately 1,400 people in person, but also we have reached more than 600 online. For research, we have shown that our training model is effective when combined with non-technical skills while teaching ACLS, but also we have shown that on the right, that our training course, which is called vital anesthesia stimulation training, is applicable to the needs of low-income settings by improving non-technical skills such as teamwork, situational awareness, decision making, and task management. We have also done some advocacy work where we have summarized our previous work and suggested our next steps. Can also help decision makers to support the program, but also other scholars from across Africa to publish their work so that we can maybe have some collaborations in the future. For the way forward, we are planning to have a sustainable resuscitation training program by collaborating with the Ministry of Health, the Rwandan Society of Anesthesia and Critical Care, the NIHR Research Hub at the University of Rwanda, which kindly has accepted to provide funding to test our model in one of the teaching hospitals. And also, we are planning that we'll conduct some, we will apply for some grants to have the database for all our resuscitation program so that we can monitor progress and implement quality improvement projects. We are planning to build the research capacity at each institution, starting by 10 hospitals. We think that will be involving resident and to have also potential for virtual simulation scenarios so that we keep reducing the time people have to take out of clinical practice. And the same line, we have to ensure that we have a program for faculty development where we plan to collaborate with the University of Rwanda to have a simulation fellowship. We are planning to have the community of practice where we are planning to have an annual symposium for all resuscitation committees in those hospitals, which may help us to grow and involve all hospitals, which are around 45. Lastly, we are planning to test our model in a different setting where we're collaborating with the University of Botswana to test our model for their student and teaching hospitals. Before I conclude, I want to acknowledge the IMEGH group. You see all the faculty who are members of our group, and also all our instructors across the country and the stakeholders, including VAST, NH, CPAs, HPR, hospitals, universities, and also our collaborators in Botswana. Thank you very much for your kind attention. If you have any question, please send your question to our email at info.imegh@gmail.com, or you can visit our website at www.imegh.net. Thank you very much for your kind attention.